Fortunately, I have an incredible group of panelists here with me to have the conversation about engagement strategies, so they will make my job very easy. But before we begin, I wanted to share a bit about why this panel is happening. I think you guys have noticed that we're doing this kind of at the beginning of each panel, and I think it's important to kind of establish the reason that we're here for each of these sessions. There's a very strong intention behind the way that we crafted the agenda this year. So as Mary mentioned, we are building on some of the themes that came through repeatedly during last year's conference in Atlanta. But I want to emphasize that it's not just about the importance of building trust, but also knowing why going the extra mile to think about health equity, diversity, inclusion, and accessibility is important. We learned a little bit about that in the last panel, and in this conversation, we're gonna kind of continue that by hearing from some of our panelists who are doing that work. And our approach is not and should not be about just filling a quota. You don't want to be thinking about just checking the diversity box, making sure you get that disability advocate in there, making sure you get your representative from a Black community or Hispanic community. Because if we're not thinking about the entire ecosystem of humanity, we are missing a huge portion of the population that is affected by rare diseases. We need to consider all factors of rare to ensure that when we get to the stage of conducting research and developing treatments, that those treatments are effective and accessible for all populations. That will be touched on a little bit with Connie through her Breaking Barriers program. And everyone, regardless of their background, deserves the same care, support, and chance at life. To that end, I'm actually going to start by having each of our panelists introduce themselves and provide a brief background on the community that they are involved with, as well as how they initially got started kind of working in that community. So, Connie, we'll start with you, and then we'll go down the line.
Okay. Hi, everyone. Thanks so much for having me. I've been part of the rare disease community for over 20 years, and this is my first time at Global Genes, which has amazed Rachel to no end, and I want to thank you for inviting me. I started what used to be called the Angioma Alliance and is now the Alliance to Cure Cavernous Malformation. Our disease is a rare disease that involves abnormal blood vessels in the brain or spinal cord. There are genetic forms, there are sporadic forms. One of the programs that I'm going to be talking about today is a program that focuses on Hispanic families in New Mexico. And the reason these families are important is because they have a founder mutation. And for those of you that are new to genetics, founder mutations happen in autosomal dominant diseases. So each child has a 50-50 chance of inheriting the disease if there's an affected parent. Usually founder mutations only happen in diseases where the phenotype is somewhat light or where the disease is an adult onset disease. So the kids grow up to be adults and they have kids. You have to be able to live long enough to reproduce and have children. So with our disease, that's exactly what happens. Sometimes children are affected, but most often it shows itself between the ages of 20 and 40. What we discovered in the 1990s is that there is a group of families, a significantly big group of families in the state of New Mexico that all have the exact same genetic mutation on chromosome 7, and it's called the common Hispanic mutation of the CCM1 gene. We now know, we didn't back then, but we now know that the founder of this mutation was born in the 1600s. So this mutation has traveled down generation through generation through generation to the point where there are now probably 30,000 to 40,000 people in the state of New Mexico alone who are all distantly related but have the exact same mutation, don't know each other. So our work, of course, in New Mexico was critical. We started there in 2006. We had a patient conference there. We started trying to work with the legislature. We developed relationships with the University of New Mexico. But in the end, doing that, we got very little leverage. For the longest time, 2006 through 2016, the number of patients that would engage with us and become part of our communities grew very slowly, especially relative to the number of people that are there. And I want to sidestep for just a moment to say that we have two programs. One of them is in New Mexico, and then a second program that we started more recently is called Breaking Barriers, and it is engaging Black patients. That is a national program. And one of the questions I'll be speaking to, I think, that Rachel's going to ask me is the difference between working with geographically concentrated families versus families that are dispersed. Going back to New Mexico. So what did we do? In 2016, we applied for a PCORI grant and didn't get it. But part of the process of applying for the grant was having an Alan Alda science communication 3-day miming workshop thing. I got to go to that, which I was very excited about, and it's more than just miming. We actually do get to learn how to talk to each other, scientists, physicians, and patients about science, but I remember the miming part best because it was kind of weird. And at that meeting, the patients were expressing what was important to them. And what I could hear was not, oh, it's important to me in my family that all these people are having strokes and seizures, are dying young, et cetera, et cetera. What I heard was, we are all related. We are from the founding Hispanic families, and that given that there's a large indigenous community in New Mexico, it's a very Hispanocentric viewpoint, but from their perspective, they were part of the founding families of the state of New Mexico, and this was something that was of value to them. So I walked away from that thinking, this is where the passion is. This is what's important to the families that we could be working with in New Mexico. And we decided, me talking to a number of the families that we did have contact with, along with the rest of my staff and board, to apply for grants that might enable us to speak to that passion. So we started something called the Baca Family Historical Project. We completely removed the name Angioma Alliance from the project, dissociated it thematically from our organization, and the point of the project was to help fill out the family tree so that we could find out where the at-risk families were, help to destigmatize the illness by recognizing that connection to the original families, and then work with the community partners. We worked with community health workers in large part, and this is an enormous resource that I think is underutilized everywhere, but in New Mexico, it's a very well-developed resource. And so we were able to train 800 community health workers about our disease and what to look for and what names even to look for that might be more at risk. We worked with historical libraries. We worked with community centers, senior centers. We worked a lot with the media. We worked with other medical providers than the traditional ones that we typically were reaching out to, not just the neurologists and neurosurgeons. It became a full force effort, and by the end of 4 years, which is when our funding ended, we had 4 years of very intense work. CCM1, which is how they term the illness there, became a household word in Hispanic families in the state of New Mexico. Probably almost anywhere you go right now in New Mexico, if you say CCM1, they would go, oh yeah, it's that Baca family thing. But they would know what it was. When we engaged with patients, we invited not patients, but the whole community. And in some cases, this was small towns with spaghetti dinners. In other cases, it was in Albuquerque where we took over the historic museum. We would bring them in. We would bring in speakers from the New Mexico Genealogical Society who would talk with them about the history of the Baca family in the state. And then someone else would talk about their own family tree, and then we would introduce, and oh yeah, in this family tree, this illness exists. And then we would talk about what this illness is and what the implications are. And then we would say, let's have a little family tree workshop. Let's see if you are in an at-risk line. And if you are, would you like genetic testing? And so the genetic testing became the way that we were able to continue to work with these patients after the meetings. Once they were tested, the results were sent to their doctors, not to them. We could test there at the conference, but we could not share the results with them. And we could help them engage with us and with the greater medical community. I don't know how long.
I'll stop you there and there's so much to dig into,
yeah.
So we'll get into it.
All right.
But I told you they'd make my job easy. I'll give Carla some time and Dr. Brown some time, and then we can keep going.
Well, hello, everybody. I'm Carla Brigatti. I'm a genetic counselor, and I'm the Research Operations Director at the Clinic for Special Children in Strasburg, Pennsylvania. So we're a small, nonprofit medical clinic based in southern Lancaster County, really that was built by the Amish and Mennonite community and is there to serve the Amish and Mennonite community. We collectively term the Amish and Mennonite the plain communities because of their traditions in sort of shying away from tokens of vanity. So they don't dress very differently from one another. They don't wear wedding rings. They don't wear buttons in a lot of respects. And really sort of choose a very simple agrarian lifestyle where they intermarry amongst themselves and practice very sort of simple Christian values that have been handed down to them since they first emigrated to the United States in seeking religious freedom at the invitation of William Penn many, many years ago. And so the Amish and Mennonite are not new to medical genetics in the sense that because of the founder effect, which Connie nicely teed up, we knew that they have a unique constellation of genetic concerns and rare disorders that were ultra rare outside of their own communities. And they had long been studied and contributed to medical science directly. But there had never been before a place where they could go to learn and to be impacted by those findings in changing the outcomes of their own health and well-being and so forth. And so in 1989, the Clinic for Special Children was founded on land donated by an Amish farmer in the back of a cornfield. So we literally, you have to go through a bunch of cornfields in order to arrive at our door. And it was built in a day by those communities because they recognized that unless they found a way to enable their own change in their health and well-being, that no other place was going to do it. And so together with our founder, Dr. Holmes Morton, over 30 years now, we've really sort of made milestones in understanding their genetic association with disorders and made a very concerted effort to translate the implications of those findings to the general population as well, all while engaging continuously with these communities to ensure that we're meeting their needs, addressing their questions, and ensuring that they're stakeholders at the table when discussing this with sponsored studies or other academic collaborators or other nonprofit organizations and so forth. So I think that
it's a great introduction, Dr. Brown.
Hi, everybody. I'm Italo. I tend to be very casual. I use he, him pronouns. I get very nervous when I talk, so I just want you all to know that I'm up here really putting myself through it. But no, I take pride in being not just a practicing emergency physician, being from California. I'm from Sacramento, California, born and raised, and went to a historically black college in Morehouse College. That informs the passion that I approach this work with. I also trained at Meharry Medical College, which is another historically black college. So emergency medicine is very unique in that you see people at the most desperate times in their lives, and you see anyone across the entire spectrum of illness. And in that space, I've been able to have some of the greatest impact. I'm proud of working at Stanford as both a physician and also the head of their Social Justice and Health Equity Curriculum Committee. So I help other medical students and blossoming physicians learn how to talk the language of health equity and justice. Something I take passion in, a lot of pride in. But more than that, the community work is what resonates within my spirit. I've been working in barbershops and doing health-related barbershop initiatives probably since about 2008. In 2014, a colleague of mine from Morehouse, his name is Jamil Lacey, he's now in medical school, decided he wanted to come up with a group called Trap Medicine. For those that never heard the casual term trap can be used to describe something that you can't get out of or feeling like it is closing in on you. It could also mean working really hard and hustling to try to create something out of nothing. And TRAP stands for Trust, Research, Access, and Prevention. So from Jamil, we worked to create Trap Medicine. And trap medicine specializes in leveraging the cultural capital of Black barbershops to approach the health and wellness of Black men and boys. Trap medicine is something that was very inherent to us. If you've ever been to a Black barbershop, it's a very unique experience. For us, for Black men, it's like a country club. You know, we weren't historically allowed to go into country clubs, so we had to create our own. And these barbershops are safe spaces and cultural hubs. You can talk about everything from who's the best basketball player to where do you get the best food to how to wear a condom or how do you get tested for things. All of those conversations happen very seamlessly in this space. And what we recognize is that if you were accepted in that community, if you were able to tap into that intrinsic value and show honor to the people who are in that space, you could literally get a lot of work done. So we've been able to extend in California to about 25 different barbershops. We've approached and worked with about 45 barbershops nationwide and partnered with several different barbershop-based health initiatives as well as nursing societies, case management, and social work to try to reach and meet the needs of our key population, which is Black men and boys. Now, the unique overlap here is that when it comes to sickle cell disease in America, individuals who live and struggle with sickle cell disease are often stereotyped from the moment they approach the healthcare ecosystem. I've seen this firsthand in the emergency department where the name sickler is used casually. I've seen people denied treatment, denied pain regimen, have been essentially forced out of the emergency department and other spaces or discharged before their pain is resolved. These conversations we curate and explore in the space of the barbershop. We also approach health and wellness from a larger bird's eye standpoint, where we talk about hypertension, diabetes. We do mental health and wellness. We facilitate conversations around trauma and how to approach trauma-informed care. All of this while someone's getting a fade, or that's a haircut if you. Yeah. And I think the unique part about this overlap is we're able to not only take firsthand needs assessments and apply that information to try to improve their health opportunities, create resources on site, but also I take that and go straight to the doctors and teach them how to understand communities that they may never see. As I said, at Stanford, we have a higher population of cystic fibrosis patients, and very seldom do we see patients who have, or not seldom, we see a fewer amount of individuals with sickle cell disease. But we've been able to actually create didactic modules around how to manage sickle cell disease, as well as increase the way that we understand pain within that community. So I take a lot of pride in being able to do this work, and the goal has always been to bend the arc towards health equity.
Well, man, I wish I had a Talo superpower because if I could speak that well when I'm nervous, then I would be set for life. So I'm going to actually stick with you, Dr. Brown and Talo. We talked and we learned a little bit about some of the barriers to trust, especially in Black and African American communities in the U.S. through Mario's keynote speech this morning. So I wanted to see if you could touch a little bit on what are some of the key ways to earn that trust and build relationships within the Black and African American community for maybe patient advocacy organizations or researchers or industry folks who are have identified that maybe that is the underserved or underrepresented community they want to work with, but they're running into that barrier that, you know, there's an inherent lack of trust due to the numerous reasons that were outlined this morning. And what are kind of the similarities and unique differences compared to other underserved or other under-resourced communities?
All right, I'm gonna take this bite by bite.
Yeah, it was a lot.
First off, if I could call him Mario, excellent talk this morning. I wish they could put that on a mixtape because everybody needs to hear that. No, I'm straight up serious. It was fantastic. No, absolutely.
It'll be on our YouTube 90 days after the event. So
there it is.
You can watch it as many times as you want.
I love it. I love it. My father is an 82-year-old Black man from Saginaw, Michigan, by way of Mississippi. And he has had multiple personal traumatic experiences with going to the hospital. Everything from seeing his mother pass in the hospital to being denied care multiple times, watching his wife pass with sarcoidosis in the hospital. And I remember trying to navigate the conversation of his mistrust and distrust in physicians. And it was because of a legacy that had been basically created over the course of his lifetime. And that legacy is grandfathered into multiple generations before him. And I'm a doctor, I'm his son. So imagine how difficult it is to try to get through to another person of color when it comes to trusting the healthcare ecosystem. And then we'll turn around and we'll gaslight members of this community because, okay, why wouldn't you trust somebody who has on a white coat or someone who has access to healthcare professionals, especially when the majority of the buildings are not named after anyone who looks like members of this community, when none of the research papers are led by, or most of them are not led by people who come from this community and are not communicated directly to the community. So I take it is a very serious thing for us to understand why this distrust and mistrust exists, to even start the conversation. As I said, the lecture this morning kind of laid the terrain for that. Now, when you approach communities, especially BIPOC communities, it starts with checking your cool at the door. You cannot walk in this space assuming that you are to be trusted. What is the evidence of that? It's a currency that's very unique to us. Everything from a head nod to a dap and a handshake can be a sign of trust, a symbol of trust, and we take that very seriously. Another quick anecdote, I lived in the Bronx. I trained in the Bronx, New York for 4 years. And I walked into a community barbershop trying to do trap medicine, and they laughed me out the barbershop. I thought I was the cool guy. I said, hey, I got locks. I dapped somebody up, and they were like, nah. And I've tried that in multiple spaces, and what it's taken is time and time again showing up and asking for nothing in return. Literally going in with the whole desire to just understand who people are, leading with listening, having an exceeding amount of humility, and being willing to take a gamble. Like, that vulnerability is important. And sometimes I sit there in the barbershop when I'm trying to establish a connection with the shop owner or the shop members, and I just sit in silence, and then I try to share some of my experience. And it takes a lot of courage to just get over that hump. But again, it starts with realizing that people who have come from this community have had to do that their entire lives, have sat in spaces where they were the minority, have sat in spaces where they were automatically having to prove their existence and the reason they're supposed to be there in the first place. And so take yourself through that journey every time that you try to extend and create these connections. And I think that the last part that I'll underscore is, I think you mentioned what is the difference between trying to establish this in a community versus others. I think that there's some very clear similarities. For example, social and structural drivers of health. Note that I say drivers and not determinants. I have to put on my academician hat real quick. Determinants indicates that there is a finality to it, like it's the end. Whereas drivers is a term that we use to steer different things out of that way. So when you talk about social structural determinants, try to shift towards drivers as the word we use. But those things exist among all populations, so that is a point of commonality. Where I think there's the difference is sometimes when we seek care, we don't even see ourselves reflected in that care. The number of black male physicians has continued to dwindle since, I want to say, the 1970s. And so understand that as a black man sitting in a barbershop, your likelihood of seeing a black doctor is very slim. And so I try to be that for them and acknowledge their hurt and acknowledge the trauma, and at the same time show them that there's there's routes to this care, but ultimately leading with humility.
Yeah. Wow, thank you so much. Yeah, absolutely. One thing that you mentioned was regarding, not asking for anything in return. And I think that, Connie, we talked about that a little bit kind of when we were preparing for this session. Making sure that you're providing them the services regardless of getting them to sign up for a clinical trial or anything. You're providing them the services regardless, and then helping them understand why it is important for them to continue on that pathway and participate in research. To that end, can you contrast the different approaches to community engagement, building trust, getting them to that next step for geographically dispersed communities like many of our rare diseases families versus geographically concentrated ones?
Sure. And I think when we talk about building trust, for us, I actually put a sort of a time on it, that I don't feel comfortable asking for anything until I've spent 2 years with a community. I don't want anyone to think that I'm coming in with a secret agenda. I want to make sure that our community is growing. And that is my purpose for being there, is to offer services, to assist in improving health care and improving medical outcomes. It is not to enroll you in a trial. That is not why I'm there. If that is something that happens, 3, 4, 5 years, 6 years down the road, yay. But that's not why I'm there. And if you don't want to do that, that's fine. That's fine. So for us, getting back to your question, Rachel, when we work in New Mexico, we have the ability to be very focused. We have the ability to work with the legislature, who most recently, after finally 17 years of advocacy, approved $300,000 to be given specifically for CCM care in the state of New Mexico, including genetic testing, which is so important. That work, we engage on the very much on the ground level. We engage in the community centers, in the churches when we can, in any possible human that we can talk to, we talk to, because we know it's going to resonate. It's going to resonate because everybody has a neighbor. In some towns, it'll be 1 in 50 people will have this illness. So the work is easier. It's more, resources need to be prioritized because you could do so much there. All right, so our second program is our Breaking Barriers for Black Health program. We started that program not because the disease is more prevalent in Black patients, but because Black patients are so underrepresented in our clinical databases and in anything that we've been doing. We haven't been seeing Black families, which means we're doing something wrong. If we were doing it right, then we would be having the same representation of Black families as there should be relative to the population in the US. So this becomes a more challenging effort because there is no geographic concentration of Black families with this disease. There's no reason to think that there is a founder mutation. These are families who are spread throughout the US. There's probably 80,000 people who should be diagnosed, but across the entire country. So when you think of 40,000 in one state of New Mexico, where there are only 2 million people to start with, versus 80,000 among 330 million people, that is a much greater dispersal. So we're working now on a higher level and on a more intimate level. We make sure, we started the program with deep listening. We got an IRB-approved study together in which we were doing interviews of the Black patients that we did know, and then doing qualitative analysis of those interviews to understand better what the disease experience is. So we stopped and we listened first. And I think that's something definitely that needs to be emphasized. Do not walk in there thinking that you know what a community needs. What we were hearing was that patients were not getting follow-up care. They may get to a diagnosis, they have some acute episode that gets them the MRI if they're lucky, but even those patients who get to that point don't have aftercare. So we started one-on-one concierge care needs assessment, where we could connect people with our centers of excellence, offer them genetic testing for free, connect them to a community of other patients. So that, whereas in New Mexico, we were working more in the town level, at the level of the town, in this program, we're working at the level of the individual. However, we are also working at a much higher level. Right now, part of our initiative is to increase the number of Black neurologists. This is where the diagnosis is going to come from, and so we're partnering with Meharry, because Meharry is one of the only medical schools that has a requirement that the students do research, and we're offering awards to students who choose a neuro-based research project as part of their first and second year of medical school. And we hope to be able to do similar types of efforts in the other HBCU medical schools. So we're working on the individual level, and we're working really for some long-term outcomes. Shifting the number of Black neurologists is not something that's going to happen in the next 2 years. it is something that we hope to have accomplished in the next 5 to 10 years.
Thanks, Connie. And you mentioned that your timeline is, 2 years, and I know that for you to kind of get established, and going back to the New Mexico program, I think you said like 4 years. I think that it was from 0 to 4 years, and that time you felt like you had kind of established and worked within that community, and CCRM1 became a household name,
Yes.
Correct?
Yes.
But for Carla, it was a little bit different, right? Your timeline, and I can't exactly remember what we talked about. It was shorter, yeah? Or was it longer?
It was. I mean, I think it entailed sort of identifying real needs within the community and immediately moving forward to address those needs. So lots of one-on-one conversations with individual families in need, finding the common thread between them, and identifying an action plan that would sort of change those outcomes. And in this case, it was mostly around a condition known as glutaric aciduria type 1, which was before commonly known as Amish cerebral palsy. These children were born healthy, and within the first 2 years of life developed debilitating dystonia that really enabled, kept them imprisoned in their own bodies for the rest of their lives, so to speak. Recognizing that this was a biochemical disorder that could potentially have a therapy associated with it, Dr. Morton and his team immediately sort of sprung into action to say, what can we do together with your number of individuals that you know in the community? And so went house to house and spoke to each one of those families to sort of say, this is what we think is happening, and if we work on this together, we might find a solution. And so within the 30 years that the clinic has been there, it went from a 95% disability rate to only less than 5% nowadays. And I think demonstrating those outcomes gave us the credibility to move forward in other arenas in healthcare, in other disorders, and in other areas that we felt really identified unmet needs, and that they brought forward to us and said, this is something that we're really concerned about. What can we do to address this need? So that's an ongoing process. Other clinics have sort of sprung up around the United States that also are centered in the Plain communities. And some of them haven't been so successful in getting up and running super quickly, mostly because they've had a hard time attracting the medical talent necessary to really engage with those communities one-on-one and to advance some of their prerogatives as well.
Yeah, and I mean, you mentioned, so I think that your situation was a bit unique because the Plain community was so welcoming of Dr. Morton and willing to work with him and establish this clinic, whereas, so I think it's just important to point out that it's going to be different for kind of every community you work with, and you can't say that this is always going to be the same for Black communities. You can't say this is always going to be the same for Mennonite communities. You just showed an example of that, always the same for Hispanic communities. So really, you have to, it kind of depends on where you're working. And I wanted, Carla, to have you kind of expound a little bit more on the fact that establishing trust with a community is a dynamic process, right? It can take 2 years, it can take 4 years, it can take 30 years, it can take 3 months. But sometimes that process unearths practices or concepts that conflict with the medical organization. So what are ways to bridge these gaps with other trusted members of the community?
It's a really important question, thank you. And I think that, within the Plain communities, they don't engage readily with traditional medical care. They don't have insurance or Social Security or other entitlement programs. So the way that they relate to traditional medical care is often very different from what you and I might experience. And so one of the things is they sometimes go to non-traditional healers and so forth that are, unfortunately, have a legacy of really using practices that are not consistent with mainstream medicine and that are downright dangerous. And so it's been really sort of engaging with other trusted members of the community to sort of illustrate or illuminate some of those practices, but also to work with those who are trusted members of the community and want to do right by them. So we find that the midwifery community in the communities that we work with are super important allies in advancing healthcare practices because they deliver over 90% of babies at home for our Amish and Mennonite families and have a wide variety of training experiences. Some of them are certified nurse midwives. Some of them are community members who decide through apprenticeship and so forth that they themselves will become midwives as well. And so it's really working with all of that diverse group of people sort of educating them, learning what they're learning about the community that would be helpful for us to know, and advancing ways together where we're speaking on behalf of one another in some respects. They are ambassadors, if you will, for the work that we do at the clinic, and readily come back to us with sort of, as the eyes and ears of the community as well. And so having sort of, when we initially met those Amish families and found that we were able to make inroads, it was having them sort of speak to the power of that relationship with other family members, with other friends and so forth, letting them sort of spread the word where they had the credibility and the trust and so forth has been hugely important. So never underestimating the allies within the community itself.
Yeah. Okay, I think I have one more question, and then I know we're getting close to time, so I'll then open it up to our audience. I'm sure they have loads of questions because I know I could talk to you all for days. Matalo, I'm going to end this with you and say, we've learned a lot about the importance of building those partnerships and relationships and starting small and relying on those partnerships within the community. We've heard about midwifery. We've heard about community health workers. We're going to hear a bit more about working with community health workers and kind of the interdisciplinary care teams later this afternoon on a couple different panels. But when we're thinking about building these partnerships, how do you vet them, and what are ways that we can effectively gauge the success of these partnerships? Because it's not always going to go exactly to plan, and there are going to be folks that are trying to take advantage of what you're trying to do. And so, how do you kind of determine that?
No, certainly. I think in the last 4 or 5 years, it's become very popular to be health equity tourists. And for different organizations to literally parachute into these communities and to come with empty promises. And so we have to be very careful about how we vet these different opportunities in terms of partnerships. The first thing is, when you develop a good relationship with the community members, those trusted agents, those messengers, faith-based organizations, people who are embedded in the community and have their feet really implanted in it, you're able to have these conversations to understand what their needs are. And it creates somewhat of a guild, right? So you can either passively tell them about these opportunities or have a created group or organization that you can talk to them about these particular opportunities one by one. You can create even a process by which you vet those opportunities and formalize it, right? I think that's something that we've done very effectively. The other thing is realizing that there has to be value alignment. Just like when a company partners with another company, they focus on value alignment, and usually it's in the sense of a capitalistic idea. It's like we have to make money together. Well, we want outcomes to change. That is the goal. And however you define those outcomes, whatever your metrics are, whatever you use to kind of decide whether there's good work being done, that has to be the centered element when you make the partnership. I think that what holds people, what is the other part is you have to hold people accountable. So openly and at the front discussing what the system of accountability will look like and what it'll look like to terminate the partnership. So almost like if you're engaging in a contract, but saying openly like, hey, this is what we're expecting. This is how we want to move. And in that conversation, having somebody who is a part of that community there. So for us, what we tend to do is bring barbers in that space. They get the opportunity to, one, increase their own education and knowledge around these types of decisions, because if you don't know, most barbers don't actually have equity in their own spaces. They're usually renting the space or somehow they rent a space in the shop, or the shop itself is renting from another person. And so we try to create that as well. The other part is allowing them to take part in the process so that if there is a publication, if there is some type of output that comes from this that is scalable, they have equity in that as well. So that creates the ability to try to vet these a little bit better. And I will say that the last part is realizing that sometimes you have to stand in between the entity and the community. This has been something I've personally experienced, where the community of Oakland has a differential relationship with the institution that I work at, right? They have had ongoing conflict for years. And so when I do trap medicine, sometimes Stanford is saying, hey, we want to come in on this. And I'm like, wait a minute, the community may not have approved that. And you have to be able to say that from a very clear perspective, one that is minimizing yourself and minimizing the personal gains that you could have, while at the same time honoring the real work that needs to be done. And so I essentially say that, and it's recorded, it's okay, they know. They know how I get down. But ultimately, it does take courage to do those things. As long as you know what you're there for, you'll sleep well at night.
Wow, well, thank you all so much. This was absolutely incredible. Yeah, like I said, I could talk to you all for days, but I will allow our audience to ask any questions. If you have a question, feel free to come up to the mic in person, or Tanisha will be walking around. You can raise your hand.
I'm here first this time.
Everyone's processing. That was a lot of information to take in.
Hello. My name is Nate Milam, and I wrote this down because I thought of it really early and I thought I was going to forget it. Okay, so it's not loading, that's great. I'm representing the Histocytosis Association. I'm an ambassador. Oh, there it is. Wonderful. Cool. I scrolled a lot. We have a digital poster outside, and it's the coolest thing I've ever seen. But I am Black, I'm queer, and I'm rare. I had to undergo a bone marrow transplant to cure my rare disease 12 years after being treated for misdiagnosis. And as many of you may or may not know, that process was not easy. When you're transplanted, you need a donor, and crazy enough, Black people have the lowest percentage rate of finding a donor. It's 29%, which is lowest than any other ethnic group. Fortunately for me, I experienced a miracle, was transplanted by a 100% donor match. Modern medicine has ultimately kept me alive, despite the hiccups along the way. And even with those credentials, I struggle with convincing my fellow Black counterparts to trust in it due to the same reasons stated by Dr. Brown. I can't blame them, but sometimes no treatment isn't a viable option. What are some steps I can take to bridge the gap and trust and start assisting my fellow Black community and learning to trust the system?
Thank you for not only sharing your narrative, but also for being someone who is sharing the narrative of so many other people. When I was in college was the first time that I participated in a bone marrow drive. And I just remember it being very well DJ'd, lots of stuff for people to look at, but poorly attended. And I thought about that as you were talking about this question. We have to do two sides of work. And I would be remiss not to acknowledge that there is internal community work that needs to be done in terms of our stigma that we have against trying to save our own community members, right? If I asked everyone in that barbershop that day who would be willing to go ahead and participate in this donation today, they would be like, I don't know, man, start doing the rub off or whatever. And it's because we haven't broken those things down internally. It has not become cool yet. It has not become popular. There's no viral media. There's no TikToks on this. And so whatever we can do internally to amplify the need and the people who are truly having these success stories that you spoke of and the way it has transformed your life, I think that would go a significant way internally. Now, the external stuff, that's what we're here for, to figure out how to shift policy, create more funds to do this work. Because I guarantee if I looked at funding towards this particular thing compared to other, it would be a lot lower. And who are the ones that are involved in the funding streams? So on one side, there's policy that has to be shifted externally. There has to be resources available. On the other side, as I said, there has to be dedicated energies towards changing the stigma around this. That is how I would approach it. And I think you can scale that to almost any rare disease.
Right.
Thank you.
Can I add one thing to that? One of the things that you mentioned was that you were misdiagnosed for so long. And I think, again, more on the practice and policy side, the idea of normalizing second opinions and making it standard of care.
Golden.
It would be amazing.
Golden.
For me, whenever somebody gets a new diagnosis, that's the time to bring in a second expert. Or even if there is no diagnosis and there's symptoms that are worrying, just making sure that a second opinion is available.
Yeah, and actually to that point, we are going to have table talks tomorrow, and one of the topics at the table talks will be about kind of how to effectively share your story and convey your story to a physician in a medical appointment, and how to kind of best advocate for yourself in that space, because as we in this room all know, a lot of times you are not believed the first time around. So if you're interested in continuing that part of the conversation, you can go to that table tomorrow during our table talks. Another question.
Yeah, my name's Ben Forrid. Thank you so much. This has been an absolutely awesome first few sessions. My mind's blown. So I really just want to speak probably as a person more than as a professional. I work in healthcare. I'm based in Sioux Falls, South Dakota, but I come from rural South Dakota. And I'm the first generation of my family, people who were actually born in a hospital. Before then, people were born in a midwife at home and those kinds of things. And there's this general distrust of healthcare in general, this general distrust of modern medicine, I suppose, because the stuff that was working when my dad was growing up works now too. So we'll stick with the whatever things they're doing. And so my question is really from a person perspective. I mean, you talked about, your dad, working with your father and stuff. How can I have conversations with my aunts and uncles who are poorly managing type 2 diabetes or doing these kinds of things from a professional yet person saying, hey, I love you first and foremost. Here's where this is coming from, and still feel that pushback. What kinds of advice do you have for those sorts of situations?
It's a very interesting thing to approach. When we go into healthcare, we're like, I want to save the world. I want to be able to do this. And then you realize how difficult sometimes it is to have those discussions within your immediate nuclear family. And I think that there's some tactics I use. First is try to understand what the hesitation is. Where is the origin and the root of that? Did they have an experience? Is there a traumatic element to it? Have they, are they conspiracy theorizing around what they think is happening when the doors close? And then meet them not with, I told you so, here's data, here's facts, but just loving them and like, I understand that. I've seen this before. I've felt that same energy. The next thing that I tend to do is talk about like, what are the actual options and what are other experiences that might not be what they've seen, but people who they've trusted and who they care about that have had a different type of lived experience. And so now you're creating a corollary. It's like, well, let's say, I'll use the example of my father, right? His friend Bo is actually well engaged in healthcare. He goes and checks his prostate every year. He goes and has check-ins with his diabetes. He has medication reconciliation or something like that. And I'll share that with him and be like, and you two sit there all day and talk about CNN. So why is his experience something that doesn't necessarily work for you? And then just try to engage that. And I think another major element here is showing through actual practice. Like, I've invited my father to go with me. I'm like, I'm going to go. Do you want to come with me? Just to actually give him the opportunity to see what it's like. And sometimes that second step is extremely helpful. So I want to encourage you and say, like, keep having those dinner table conversations where health is normalized. So it doesn't feel like this taboo topic every time you bring it up, and it doesn't feel persecutory, okay? And then the last element is realize that it's not a light switch. You can't walk in a room and they be like, I love healthcare all of a sudden, or I feel seen. No, it takes incremental change, and it can be gradual. That 1 degree of success is worth fighting for.
I appreciate that answer a lot. I think a lot of people jump to health literacy. People have to become more literate, but they have to want to become literate first. And I think that's the hurdle that a lot of folks in my area of the country try to get over too much.
Right.
Yeah.
Thank you.
Thanks, Ben.
Rachel, we have a question over here.
Okay. I was going to make one comment before we go to that question. Javon Gibson, who is also here, maybe somewhere in this room, hopefully. I'm not sure if he's here yet, but he's going to be speaking on the medical care panel that's coming up. And he has spoken before at one of our events, and he does talk a little bit about kind of having to speak with his parents, I think, with the COVID vaccine and getting them engaged. And so, you can also talk to him about similar subjects. Yeah, what is the question?
My name is Chandra Wooten, and I was diagnosed with spinal cerebral ataxia type 3. And and this question is for anybody. I'm from Decatur, Georgia, but I'm originally from Marjorie, Arkansas. But spinal cerebral ataxia, is this a genetic disorder? And my family has it. Well, two of my sisters have passed, and a nephew have passed from conditions of it, and now I'm affected, and I have another sister that's affected. But my question is, we raise money to do research, but where's all the money going? Because there's no cure for it. And I've been in clinical trials, but I've got out the clinical trial because the medication wasn't helping me none. So they raise all these money for it and for cancer, but where's the money going? If they can't find a cure for it.
I can start. Yeah. I think that's an enormous question. The price, I was actually going to add on to your response to the other question, which is, I come from a working class immigrant family, and one of the things that the suspicions that my parents carried around was that the only reason the doctor wanted to see them was so that he could pay for his Mercedes. And that's why they needed follow-up appointments. And I think there's also, in a capitalist society, this real tension between the profits that happen from the medical industry versus the care that people get and the improvements that they want in their lives. And I do think that this happens more in the US than it may happen in some other countries that have a more national health care where profit isn't necessarily as big of a motivation. And so that mistrust of research, of what pharmaceutical companies are doing or other types of biotech companies, it's real, and I think there's a reason behind it, because there are a whole lot of people that make a whole lot of money whether or not something is effective. So this is probably where we need to advocate more to get more government funding for research. And again, purely my opinion, I am not speaking for my organization, but it to me feels like NIH is so underfunded relative, and any agency that's doing good work in medical research is so underfunded that things move so slowly. When you talk about repurposing drugs, it takes 2, 3, 5, 10 years to get that trial going because there's no money. Because there's no money, nobody's making a profit off of it. And so I guess what I would say is the cures aren't there because the money is not being given by the right people to the right people.
I'll just also add that it's really important that the SCA3 community be a part of that conversation about the design of those clinical trials and inclusion, exclusion criteria, and so forth. And so often, I cannot tell you how we'll see a protocol that a pharmaceutical company or an academic institution is really proud of themselves for putting together, and they had absolutely no input from the patient community. And so the feasibility, the eligibility criteria, it's doomed to fail even before it was sort of put into place. And so time and again, we've really encouraged rare disease communities to speak to their experience and what they want to see. What is the outcomes that matter most to them, and make those the priority for the design of the clinical trial and so forth. In our case, we have one condition that is ultra rare globally, but it's found in 4 to 5 Amish babies born every year. It's a form of what we call TNNT1 myopathy, where over time they lose the ability to move their muscles, the ability to breathe, the ability to swallow, and will die by 2 years of age unless they've had a trach put into place or a G-tube for feeding, and which most of our families choose not to do because they believe it's just not within their practice and cultural norms. And so getting a clinical trial to better understand the natural history of this and what are the outcomes that we would need in the event that we had a gene therapy for this disorder and so forth, no one was going to do it. And so we did it within the community ourselves. We sat down with them, all of the individual families, and said, what would you want to change in your child's development? What do you most want to learn about? And we designed the trial together. And then we found ways that we could fund it that weren't onerous, but still meaningful. And we actually just published that data because it was the only way that we were going to advance something like this was to do it ourselves. And so I encourage individual rare disease communities to really make sure that they're at the table discussing what it's like, what the clinical trial is going to look like, how those funds are going to be used. Because you're right, there's all this money raised, but where's it going to? Let's hold all of that accountable to those who are making those decisions.
I just briefly want to add a plug. There's a group called the National Minority Quality Forum, NMQF. They are operated under Senator Robin Kelly, and there are other, or Congresswoman Kelly, and there are other individuals who can take this type of a narrative and create entire advocacy arms and campaigns around it that truly resonate. And so my initial thing is always figuring out how to turn that narrative into something that is not only compelling to a staffer. That's not just necessarily your job, but this is the pathway, in my opinion. You make that narrative compelling to a staffer, elevate it to an organization like NMQF, who is filled with physicians who have an appreciation for health equity, and then let us do the fighting. That's what I always say that.